25 minutes, sir.
ನಿಮ್ಗೆ ಇಟ್ಸ್ ನೋ ಪ್ರಾಬ್ಲಮ್ ದಿವಾಕರ್.
ಸರ್ ಇಟ್ಸ್ ಆನ್ಗೋಯಿಂಗ್, ಅದು ಬಹಳಷ್ಟಿದೆ. ನೀವು ಎಲ್ಲಿ ನಿಲ್ಸಂದ್ರೆ ಅಲ್ಲಿ ನಿಲ್ಲಿಸ್ಬಿಡ್ತೇನೆ.
ಹಂಗೇನಿಲ್ಲ, ವಿಲ್ ಯು ಕ್ಯಾನ್ ರೇಂಜ್ ಅಪ್ ಟು 40, 35, 40, 45 minutes. ನೋ ಪ್ರಾಬ್ಲಮ್, ಆಯ್ತಾ? ಓಕೆ. ಐ ನೋ ದಿಸ್ ಟೈಮ್, ದಿಸ್ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್. ನಮ್ಮ ಇದರಲ್ಲಿ ಯು ಸಾ ದಟ್ ಇನ್ ಮಿಡ್ಕಾನ್ ಇದರಲ್ಲಿ ಎವ್ರಿಬಡಿ ವಾಂಟ್ಸ್ ಅದು 10 minutes, 15 minutes, 12, 30 minutes ಕಮ್ಮಿ ಆಗತ್ತೆ, ಕರೆಕ್ಟ್. ಬಟ್ ಅಟ್ ದ ಸೇಮ್ ಟೈಮ್ ಯು ಕಾಂಟ್ ಅಕಾಮಡೇಟ್, ನೋ, ಜಾಸ್ತಿ ಕೊಟ್ಟಷ್ಟು.
Sir, 1 hour ಆದ್ಮೇಲೆ ಬೇರೆ many other things will start happening in Zoom meeting, sir.
ಕರೆಕ್ಟ್. ಸಲ ಇವತ್ತು ಸಾಕದು, ಇವತ್ತಿಗೆಲ್ಲ ನಾವು It's okay, sir. We will keep the academics things going on, and once in a month, it's for surgeons to get connected. YouTube ಅಲ್ಲಿ ಇರುತ್ತೆ. Those who are making use of it, they will make use of it. ಹಾಗೆ.
Correct.
This material is there. ಆತರ. ಡಾಕ್ಟರ್ ಶೇಖಪ್ಪ ಅವ್ರು ಜಾಯ್ನ್ ಆಗಿದ್ದಾರೆ, ಬಳ್ಳಾರಿ.
ಸರ್ವೇಶ್ವರ್ ಏನಾದ್ರು ಮಾತಾಡ್ತಾ ಇರ್ಬೋದು.
ನಮಸ್ಕಾರ. ಅದೇ so Raichur team is slowly getting geared up, slow agi. So but when the meeting went on well, so
worried about registration, sir. But registration last ಗೆ ಆಗೋದು. ನೀವು ಇಷ್ಟ ಅರ್ಲಿ ಆಗಿ they should not get panicked actually.
ಹೌದು, ನಾವು we told them. ಹೆಪ್ಸೋರ್ ಮ್ಯೂಟ್ ಆಗಿದ್ರಿ,
ಹಾ ಸರ್, ಲಾಸ್ಟ್ ಮಂತ್ ಆಗೋದು ಸರ್.
ಅದೇ ಅವ್ರಿಗೆ ಹೇಳಿದ್ದು, ಸ್ವಲ್ಪ ಮಂಡೋಲ್ಕರ್ ಮತ್ತೆ ಇವರು ಸಾಗರ್, ರಮೇಶ್ ಸಾಗರ್ ತಾನೆ. We told them, Dr. ಇವರು ಜೋಶಿ ಅವರು ಬಂದಿದ್ರು, ಸಂಗಮೇಶ್. So we all told them that Naaz madam also was there, so secretary and all. ಆಗತ್ತೆ ಅಂತ ಹೇಳಿದಿವೆ. So some apprehension will be always there with the local team.
ಸರ್, ಬಳ್ಳಾರಿಗೆ ಬರ್ಲಿಕ್ಕೆ ಹೇಳ್ರಿ ಸರ್. ಸೊ ನಾವು ಒಂದು 10-15 ಜನ ಮಿನಿಮಮ್ ರಿಜಿಸ್ಟ್ರೇಷನ್ ಮಾಡಿಸ್ತೀವಿ.
ನಾವೇ ಮಾಡಿ ಕಳಿಸ್ಬಿಡೋಣ ಸುಮ್ನೆ.
ಸರ್, ಈಗ ಬರೋದು ಊರಿಗೆಲ್ಲ ಹೋಗೋದು ಬೇಕಾಗಿಲ್ಲ ಸರ್. ಓನ್ಲಿ ಫೋನ್ ಕಾಲ್ ಶುಡ್ ಸ್ಟಾಪ್ ದಟ್.
ಇಲ್ಲ ಸರ್, ಕೆಲವೊಬ್ರು ಎಕ್ಸ್ಪೆಕ್ಟ್ ಮಾಡ್ತಾರೆ, ಅದಕ್ಕೆ ಹೇಳ್ತಾ ಇದೀನಿ. ನಾವೇನ್ ಮಾಡಿಸ್ಬಿಡ್ತೀವಿ, ಕೆಲವೊಬ್ರಿಗೆ ಬಂದೇ ಇಲ್ಲ ಇದೆಲ್ಲ ಅಂತ. ನಿಯರ್ ಬೈ ಅಲ್ಲ ಸರ್,
ಅಲ್ಲ ಶೇಖಪ್ಪ,
2 hour ಜರ್ನಿ
ಅಲ್ಲ ಶೇಖಪ್ಪ, ಕರೆಕ್ಟ್. ನೀವು ನಿಯರ್ ಬೈ ಆದ್ರೆ ಪರವಾಗಿಲ್ಲ, ಬಟ್ ಅದರ್ವೈಸ್ ಈಗ ಅದು ದಟ್ ಓಲ್ಡ್ ಜನರೇಷನ್ ಇಸ್ ಗಾನ್ ಹೂ ಎಕ್ಸ್ಪೆಕ್ಟ್ ದಟ್. The phone calls are good enough and WhatsApps are also good enough. Sir,
okay,
so a lot of people are asking me for the sponsorship. So ಯಾರ್ಗೆ ಹೇಳಿ ಸರ್? ರಮೇಶ್ ಹತ್ರ ಕನೆಕ್ಟ್ ಮಾಡ್ಲೋ?
Yes sir, ರಮೇಶ್ ಹತ್ರ ಸರ್.
ರಮೇಶ್
ಓಕೆ, ರಮೇಶ್ ನಂಬರ್ ಕೊಟ್ಟು ಕಳಿಸ್ತೀನಿ ಹಂಗಾರೆ.
ಇದು
ರಮೇಶ್ಗೆ ನಿಮ್ಗೆ ಫೋನ್ ಮಾಡಕ್ಕೂ ಹೇಳ್ತೀನಿ ಸರ್.
No problem. I have his number. I'll call him. I'll only call him. Not an issue.
Yeah, please.
Actually, ಅದೇ ಮೊನ್ನೆ ಬಳ್ಳಾರಿಯಲ್ಲಿ ಮೀಟಿಂಗ್ ಅಲ್ಲಿ ಎಕ್ಸ್ಪ್ರೆಸ್ಡ್, ನೀವು ಹೇಳಿದಾಗೆ ಡಾಕ್ಟರ್ ಶೇಖಪ್ಪನವರೇ, ಅವರು ಆಲ್ ದ ವೇ ರಾಯಚೂರು ಹತ್ರ ಇರ್ಬೋದು, ಬಟ್ ಪ್ರಾಬಬ್ಲಿ ಇಟ್ ಇಸ್ ನಾಟ್ ರಿಕ್ವೈರ್ಡ್.
ಚೇರ್ಮನ್ ಸರ್, ಶುರು ಮಾಡ್ಬಿಡೋಣ. ಪೀಪಲ್ ಆರ್ ಜಾಯ್ನಿಂಗ್ ಅಂಡ್ ಲಿವಿಂಗ್. ಐ ಥಿಂಕ್ ಬೆಟರ್ ವಿ ಸ್ಟಾರ್ಟ್.
ಎಸ್, ಸರ್ವೇಶ್, ಡಾಕ್ಟರ್ ಸರ್ವೇಶ್, ಸ್ಟಾರ್ಟ್ ಮಾಡೋಣ.
Yes sir.
Hello. Hello.
ಸರಿ, ಕೇಳಿಸ್ತಾ ಇದೆ.
Please start ಮಾಡೋಣ.
ಸ್ಟಾರ್ಟ್ ಮಾಡೋಣ ಸರ್.
Yes, please.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. Today we are continuing with the surgeon's time with our National Honorary Secretary as the speaker and our KJS Chief Editor as the moderator, along with our Honorary Treasurer Dr. Gurubasavana. I welcome our Chairman Dr. K. Rajgopal Shenoy for today's program. I request him to conduct the program. Sir, please.
ನಮಸ್ಕಾರ ಎಲ್ರಿಗೂ. Navaratriya Shubhashayagalu. Have a happy Navaratri days. And I appreciate Pratyobra time is important. You have given some time for attend this program. Idu namdu 7th surgeon's time. So we are started in March. So today we have a pediatric surgery topic we have selected. It also helps for the postgraduates who are appearing for exam. So it's my important duty to say 2 lines about Dr. Gaddi Diwakar, was with me, executive committee member in the initial part, and now you know that he's honorary secretary of ASI Surgeons of India. Apart from his degree, what you are seeing, professor head and medical superintendent, Ballari Medical College Institute of Medical Science. I am also from the same college. He is very, very meticulous, dedicated, and disciplined. No wonder that he has also been, actually selected for the prestigious post of the honorary secretary. And we are extremely happy to have Dr. Gaddi Diwakar with us for this surgeon's time. I wholeheartedly welcome you. And before we hand over proceedings to you, it's my also duty to welcome each one of you. And Dr. Venkatesh, you know the chief editor of the Karnataka Journal of Surgery and also head of the Department of Pediatric Surgery. So I request you to moderate this session and then introduce Gaddi and then go ahead with that. Thank you very much for each one of you.
Yes, sir.
Dr. Venkatesh, please.
Yes, sir. It's a pleasure and a privilege to have me as a moderator. I also represent state IAPS chapter as a chairman of that. And it's a privilege to have Gaddi, sir. He is my mentor, he is my guide, all that. And he is the ASI secretary, and everybody knows he is a popular pediatric surgeon, not only across Bellary, Karnataka, he is across now, he is famous. He is doing a great job as a ASI secretary. I still wonder how he found time for this academic session. It's very nice to have you, Gaddi, sir. You are the special officer, medical superintendent, pediatric surgeon, academician, the ASI secretary. I don't know how you are managing so many. And you are the chief of that Kannada Vaidya Sahitya Barahagarara Sangha. You did a great job at Ballari, I suppose. So we'll not waste time. I think it needs 1 hour to introduce you. So because everybody knows you, will directly come to the pediatric surgery proper. I'm also being pediatric surgeon at Bangalore Medical College, and I'm alumni of Ballari also. So we'll come directly to the pediatric surgeon. What a pediatrics, like how it is different from adult surgery. And you are going to talk about that. And your title says basic pediatric surgery, how to do it correctly. Because we have seen many adult surgeons doing pediatric hernias, hydrocele with recurrences. We get so many recurrences, complications, and very large scars. And doing simple circumcision by a pediatric surgeon is totally different from what an adult surgeon does. These are all day-to-day surgeries, say appendectomy. See, all these common surgeries, say less than 18 years is the domain of pediatric surgeon. Anything above 18 is an adult surgeon. So kindly enlighten us regarding the basic pediatric surgery, sir. And initially, you can tell us what exactly is the difference between the pediatric population, say newborn, say infant, adolescent, adult. We have children. So just give us a few differences exactly between the pediatric surgical patients and the adult surgical patients. Please go ahead, sir.
Yes, sir. Thank you very much, Dr. Venkatesh. Elrigu namaskara. At the outset, I would like to thank KCASI, my home chapter, for giving me this opportunity to present on basic pediatric surgery, how to do it correctly. My gratitude to Dr. Rajgopal, Shenoy sir, Chairman KCASI, Dr. Sarvesha, Raje, Secretary of KCASI, Dr. Gurubasavana, Treasurer, Chairman-elect Dr. Naaz Jahan Shaikh, and past Chairman Dr. Narayan Hepsur, who is there in the audience, and all the EC members of KCASI. It is because of you that I have become Secretary of ASI. It's all because of your good wishes and also blessings of the seniors. And for this, there has been a meticulous help of Dr. Naaz, whom I should take the name, and also Dr. Aruna, who were instrumental in conducting KSC ASICON from my home in 2019 and 20. That was the one which gave me visibility in the national ASI platform. And I thank wholeheartedly those two ladies behind my success. Thank you very much, Naaz ma'am. And so coming to the basics of pediatric surgery, how to do it correctly, my mandate was to present some videos on basic pediatric surgery. This talk is basically meant for postgraduate students, and this doesn't go beyond teaching postgraduate students. So the difference between, as Dr. Venkatesh, I thank him for moderating this session. I requested him to moderate this session. He is the chairman-elect for our Indian Association of Pediatric Surgeons for Karnataka State Chapter. Congratulations to him. He asked me to mention the differences between pediatric population and the adult population. As we all know that the pediatric population is not a miniature of adult population. They have a specific needs, especially in the neonates. They have specific needs of temperature, specific needs of electrolyte balance, and they're very fragile. Basically, they need to be handled very delicately. And pediatric surgery, for that matter, can be divided into various subspecialties. Like it can be a pediatric gastroenterology, pediatric urology, which constitutes 50% of the pediatric surgery, and also pediatric neurosurgery. Couple of institutes, we still at Vijayawada, we do pediatric neurosurgery, including shunts, meningomyelocele, and basic spinal cord tumors we used to operate. There is again general pediatric surgery, as we all do. On the left hand side is the Ballari Medical College and the Research Center, where I did my MS, MBBS and MS, and at present I'm working as a professor and head of the Department of Pediatric Surgery. On the right side of the screen is Vijayawada Hospital, where I did my MCH in pediatric surgery. These two are the places where I got to learn my skills, and that those two institutes helped me to reach the stage where I am now. And to begin with, let me discuss, like for general surgeons, it is the appendix, which is the bread and butter. For us, phimosis, circumcision and hernia are like bread, butter and jam for us, for pediatric surgeons. So what exactly is phimosis? To put it simply, it is inability to retract the profuse, because orifice of the profuse is too small to retract over the glans penis. There is inability of retraction of the profuse. So when you see this picture, this shows the normal foreskin, which we call it as profuse, and when it is retracted, it has to be retracted like this. So when does profuse start retracting? Does it retract in all the children? So before understanding that, what is phimosis? It can be classified into two types. That is a physiological phimosis, pathological or obstructive phimosis. The physiological phimosis is a developmental stage. When the penis is being formed, the profuse is undersurface of the profuse is attached to the glands, and it cannot be retracted back in childhood, which persists for 3 to 5 years of age. In majority of the children, profuse starts retracting after 3 to 5 years of age. That is normal, physiological, and majority of the times the pediatricians send these patients as phimosis, which requires surgery, and all these cases do not require surgery. And vis-a-vis, the other condition is pathological, which is obstructive phimosis, where there is recurrent infections of the subprofusal space because of the smegma collection, that is known as balanoposthitis, causes fibrosis of the profusal orifice, which you can see. There is a totally fibrotic ring is formed at the profusal orifice, and it cannot be retracted back over the glans penis. So these are a couple of more pictures where the profuse is adherent to the glands, and also the meatus of external urinary meatus is not visible. A fibrous ring is formed here. There is balanoposthitis causing a red discharge at the tip of the penis. So this is a most common condition in the children. As I said, it can be classified as physiological phimosis or pathological phimosis. So as I told, when does profuse starts retracting? It is at the age of 3 to 5 years due to the lysis of adhesions between the glands and the profuse. How does this lysis occur? The smegma, which collects in the subprofusal space, it extravasates through the profuse. That is how the adhesions get lysed, and patients and the parents bring their children to us saying that there is some swelling within the prepuce. That is usually a smegma collection which doesn't require to be done anything to do with it. Either extrudes itself out, or sometimes a gentle adhesiolysis, retraction of the preputial skin and cleaning of the subpreputial space suffices treatment of those smegma collections. So the pediatricians are in the habit of prescribing steroid ointments. Are they helpful? And what is the treatment of physiological phimosis, and when is circumcision indicated? These are the questions which come to my mind when we classify phimosis as physiological or pathological. So usually parents bring child to us with complaints of straining during micturition, ballooning of the prepuce, or weak or thin stream of the urine as shown in the picture, or recurrent balanitis or ballonopastitis or only pastitis. The staining during micturition in children, especially the neonates and less than 1 year of age, is normal actually. The child goes into a pose where it stiffens its body and starts straining while passing urine and stools. That is quite normal physiological activity. That should not be of anything of concern. But is ballooning of prepuce a thing of concern? Usually I say it's not a thing of concern also, unless it is complicated by recurrent balanitis or ballonopastitis. Even a thin or weak stream of the urine is not an indication for surgery when the tip of the prepuce is soft and supple and there is no fibrotic ring formation. So what is the treatment? As I told, the topical steroid creams, the pediatricians and we too sometimes do write as what you call placebo for the children who do not require surgery. The cortisone, effect of the cortisone application is equivocal. Majority of the times, in my experience, it doesn't work. And what should be the treatment of physiological phimosis then? The parents will not be happy unless you do something to them. What we have to do is a gentle stretching of the foreskin, that is called as adhesiolysis, which is effective in physiological phimosis. This is how we do the adhesiolysis. The child is restrained or by vocal anesthesia. The parents will be holding the hand and the leg with a small mosquito artery forceps, gently spread open the prepuce. It should not be very vigorous or rough. You should be very gentle in handling, because overstretching will cause fissuring of the preputial skin, which leads to fibrotic activity. So this is the simple adhesiolysis. Retract back, clean the subpreputial space and then leave it. And ask the parents to retract the prepuce daily when they give bath to the child, and apply some liniment or ointment in the undersurface so that it stays open. So this is suffices, adhesiolysis suffices the treatment of physiological phimosis. So is circumcision indicated in the early childhood? Majority of the children, especially, they bring us for ritual circumcision. So ritual circumcision, or for that matter any circumcision at a very young age, can cause meatal stenosis due to the exposure of the glands to the undersurface of either the underwear or the diapers. It causes the meatal ulcers and leading to meatal stenosis finally. So then when is circumcision indicated? The ritual circumcision as followed by a particular community, it can be done because it is according to their faith. But when it comes to medical condition, it has to be a pathological phimosis when that is the only indication of circumcision. So what is the procedure of circumcision? The various procedures indicated. There are minimal, what you call minimal surgery can be done, where with the use of some instruments, or the commonly followed procedure is under anesthesia. We cut the preputial skin as shown in the picture, and then approximate the distal proximal skin to the cuff of the inner preputial skin left at the corona. So to do that, it can be, if it is a child is very engaged, it has to be generally done under sedation with a local penile block or the ring block. If the child is of understandable age, say it's at 9 years or 10 years, usually they are cooperative. A dorsal the penile block is given. To understand that, we have to know the nerve supply of the penis. The penis has two nerves as shown here, the dorsal nerves, one on the right side and one on the left side. So I'll be showing the technique of giving anesthesia. So the child under sedation, a long needle is inserted at the base of the penis on the dorsal surface, and it is directed towards both the ligaments of penis. That is where exactly the nerves will be exiting and entering the penis. So, and apart from that, on the undersurface of the penis also, the anesthesia, the lignocaine, 1 or 2% lignocaine, 3 milligram per kg diluted, needs to be given even on the undersurface of the penis at the frenulum. It needs to be given. So a ring block, and it can be infiltrated all around the penis. So gently retract. If you find any adhesions, just gently lyse them with a mosquito forceps. As you can see, it is very firmly adherent to the undersurface of prepuce. You can see the fissuring of the preputial skin on the gentle widening of the preputial opening. So retract, clean the undersurface. There will be adhesions near the corona between the inner preputial skin and the glands. You have to open them up totally. So I'm opening that. The technique which I am following, some people, like the ritual circumcision, they tend to protect the glands with some help of some instrument and then cut the skin. That is called as guillotine method. I'll be showing you across again in a couple of other videos. That's little dangerous. That's what you call mentioned to be condemned, because there is always a chance. This is how they protect with some instrument. The glands is pushed down, the skin is pulled up, the foreskin is pulled up, and then with a scalpel it is cut. This is I'm showing. I'm not going to cut in this picture, just I'm showing. So hold it, and then people tend to cut, which is not recommended, because there is always a chance of you injuring the glands without your knowledge. So that should not be done. What you have to do, the demonstration is about dorsal slit method. An artery is applied on either side. The mosquito forceps is applied on either side at 3 o'clock and 6 o'clock position. Sorry, 3 o'clock and 9 o'clock position. A dorsal slit is made at 12 o'clock position, and again a ventral slit is made along the frenulum at 6 o'clock position, and that incision is carried for 360 degrees all around. Leaving a cuff of skin of 3 to 5 millimeters near the corona. Cut the skin in a circumferential fashion, and then you approximate the proximal skin, taking care that the midline raphe is aligned with the frenulum, so that the penis will not be torted at the end of the procedure. Couple of stitches are placed all around, one at 12 o'clock position. A box stitch is placed on the undersurface to control the bleeding of the frenular vessels. That's how a box stitch is taken at the frenular side. This is the dorsal stitch. Couple of stitches are placed on either side to make it look nice. At the end of the procedure, there should be a good cuff of inner preputial skin around the corona.
Diwakar sir, are you mentioning about contraindications?
Yes, sir. Yes, sir.
Okay.
So this is how it is done. The couple of other methods where we quickly I'll run through that. This is the guillotine technique which I was mentioning. So the guillotine technique, you mark the incision all around. So here people are using bone cutter to cut the preputial skin along the marking. And as I said earlier, the couple of stitches are placed to make it look good. So if there is any excess of skin left out, that is cut around. The indications as mentioned is phimosis, paraphimosis, religious, cosmesis, lesions or trauma, and recurrent. If there are recurrent otites, especially in the patients of vesico-ureteric reflux, this is done electively. The circumcision is done electively. This is one. The second thing is another kind of procedure is this is the dorsal slit technique, which I showed. So the contraindications are bleeding disorders. If the patient has a bleeding disorder, if there is a cordy or a patient has hypospadias, this procedures of circumcision should not be done, because in hypospadias the skin comes in handy to create the urethral tube. If there is a what you call cordy, then that needs to be corrected first before going on to do a circumcision, which anyway at the end of the surgery it will have a circumcised look. And especially with the bleeding disorder, sometimes it is at the time of circumcision that the patient and the treating doctor comes to know the child has some hematopoietic abnormalities. This is again the incision is being marked on the profuse. This is for dorsal or the sleeve technique of circumcision. Here the incision is marked. First, the outside skin is incised circumferentially all across, taking care that it winds up on the frenular side. It should not be exactly round. It's kind of points out at the frenulum on the upper side. So this is how the incision is made all around.
Just to update the audience, if you find a megamiatus, when you retract the skin, the prepuce, so it's one of the type of hypospadias again.
Yes, sir, rightly said. After cutting the outer skin, the inner skin is also cut. And this is the dorsal skin slit technique, which I mentioned, I showed in detail. That is the standard technique which is followed all over. So I'll skip that for want of time. This is the dorsal slit technique which is being demonstrated. These are all unedited videos, so I'll be just rushing through them. I kept it that way so that people should know, or the students should know what exactly how it is done, where exactly is the bidding, and this should be the final look, how the penis should look at the end of the circumcision. This is again a plastipel technique, which is a minimal, you can say it as a minimal invasive circumcision method, where a dorsal slit is made. The dorsal part of the skin is crushed to prevent bleeding. Dorsal slit is made. There is a plastipel device. It's a device where the inner part is inserted inside the profuse, so that the bell sits on the glands. The profusal skin is pulled over. There is a groove on the plastipel device which is tied with a thread or a suture. So due to the ischemia, the distal part of the skin, the foreskin, falls off. But the complications are that if there is an ill-fitting plastibel, or if the suture is not tied properly, the desired effect will not come. Or if there is an ill-defined, ill-fitting plastibel device is there, it will cause injury to the glands. And it takes 7 to 8 days for the distal part to fall off. This is use of the plastibel devices. This can be used in a neonatal circumcision. So that was it. So what are the other methods traditionally which have been used for doing circumcision? This is called as, this instrument is known as a Mogen clamp. This Mogen clamp is similar to the what I showed as a guillotine method. The shield which is present here protects the glands, and the foreskin is pulled through this slit, and the distal to that the foreskin is cut, and this shield is supposed to protect the glans penis. The plastibell device looks like this with a suture which needs to be tied around this groove. And this is how the plastibell, the diagrammatic representation, how the plastibell needs to be used, where an incision is made on the dorsum. This plastibell device is inserted and a suture is tied around the groove here, and this distal part is clipped off, so that after 7 to 8 days or 3 to 7 days it is given. It usually takes 7 days for the foreskin to fall off. This is a useful technique in the neonates which can be done under minimal anesthesia or a local anesthesia. These are the history shows that the various types of devices have been used for doing circumcision. This device is known as Gomco, where this is taken out. The glans is slit. The prepuce is slit. This bell goes and sits over the glans. This is then inserted within the prepuce, and this nut here is tightened so that the prepuce is pulled up, and a guillotine technique is used to cut off the skin. This is again a Kscasi ring. There are a couple of rings which I will be showing diagrammatic presentation here. This is how a shrine ring or the Kscasi ring is used. A dorsal slit is made. Usually a ring has two parts. One is the inner part and the outer part. Inner part is inserted within the prepuce, and then the outer ring is applied, and distal to that the skin is cut, or it is left to undergo ischemia. These devices have been used historically. They should be mentioned to know that there are various other methods which have been used to do the circumcision. But if you want to do a neonatal circumcision, the plastibell device is the best, or you have to do it under anesthesia. The dorsal slit technique or the sleeve resection technique are the two best suitable methods, unlike any other guillotine technique. The guillotine technique should never be used. And one more thing is that the bone cutter, which is used for guillotine method, the first video showed that. And at this juncture, I should acknowledge Dr. Akshay Kalawant, who has been a friend of mine and works in SDM Medical College as associate professor. The couple of videos have been given by him. I acknowledge his videos here. And what are the complications of circumcision? Everything is not hunky-dory. So there can be a post-op bleeding. And what you should do for intra-op bleeding? The intra-op bleeding, the ideal way is to clip them, catch the bleeding vessel with a mosquito and tie them. That is the safest way. Or if at all you are using an energy device, it has to be a bipolar cautery at the low setting. Never ever use a monopolar cautery, because the monopolar penis being an end organ, a monopolar cautery can cause vasoconstriction, and a couple of instances where the entire penis has undergone necrosis have been witnessed. So never ever use a monopolar cautery for control of intraoperative bleeding while you are doing a circumcision. And the intraoperatively, and what are the post-op complications? It can be a post-op bleeding. It will be a very minor, but at the same time you should have if there is a persistent bleeding, as I mentioned, you should rule out the bleeding disorders. Infection, very rarely, especially in adults, it is seen when there is diabetes mellitus, but in neonatal or pediatric population, the infection is less likely. And as I mentioned in the early part of my the talk, stenosis of the external urinary meatus because of the early neonatal circumcision and constant exposure to urine coated diaper undergarments, so that can cause the urinary external meatal ulcer and stenosis of the external urinary meatus. So other complications are one to do on the time frame. During surgery, it can be excessive bleeding or accidental injury associated with forceps guided method. That's the guillotine method. Or 1 to 2 days after surgery, it can be hematoma formation or the wound disruption. After 1 to 2 weeks, it can be again sometimes Fournier's gangrene or gangrene of penis and scrotum has been seen, tetanus infections, and late complications. When you do an early circumcision, there is a decreased glans sensitivity or oversensitivity of the glands can come. Some patients become very panicky. They keep coming, especially in the age group of 7 to 10 years. And sometimes if the cosmesis is not done, as I said, if the proper cuff is not left out, so it can give an unsightly scar. Sometimes if inner propusional skin is kept too long, it can again reform adhesions to the glands, and there can be inclusion cysts. Sometimes a healing can cause keloid or erectile discomfort. Some patients, if the skin is cut too much, some erectile discomfort can be there. And as I said, if the frenulum is not aligned with the median raphe on the undersurface of the penile shaft skin, the torsion or misalignment of the skin and the penile shaft can happen. This is a possibility. So you have to take care of alignment of the propuse when you are suturing. So that completes circumcision. If there are any doubts, Venkatesh, should I?
I want to give one more message to them. So when they retract the skin before cutting the extra prepucial skin, they should know one more entity called megameatus, intact prepuce. So if they find the megameatus, it's a type of hypospadias again. Just it's an academic thing. Just they should remember what is megameatus, intact prepuce. Yes. It ends up being a MAGP, meatal advancement and glanduloplasty incorporated. That's a hypospadias surgery. Yes, sir. You can go for the second one, sir.
Yes, sir. So I'll restrict my talk because I've already finished 20 minutes of that. I'll restrict myself to congenital inguinal hernia.
Gaddi, sir, you can go for this. Undescended testis.
Yes. So
if I think if crowd has got, they can put it in the chat box if they have any queries.
Yes, sir. That's better. Yes, you can take up at the end of this thing. So what exactly is congenital inguinal hernia? It's usually a protrusion of the sac of the peritoneum through the congenital or acquired defect in the muscle of the abdominal wall. Usually what happens is that the testis, when it descends from the intra-abdominal location through the inguinal canal into the scrotum, it brings out what you call a knuckle or a process of peritoneum. So usually that gets obliterated when the child is born. This shows that this is the peritoneal cavity. This is the obliterated processus vaginalis and the vas deferens. And this is the tunica vaginalis surrounding the testis. So this processus vaginalis usually gets obliterated in 80% of the children. But when it fails to get obliterated, it can present in any of these 5 ways. The first one is the normal. Second one is an inguinal hernia. That's you can call it as a bubenocele. Or this is a complete inguinal hernia when the total sac is patent right from the inguinal internal inguinal ring to the base of the scrotum. Or it can be hydrocele of the cord when there is an island of a cyst kind of thing forms. Or it can be communicating hydrocele where only the fluid goes and comes out of the peritoneal cavity. So inguinal hernia has been known since ages, and usually, as I said, it is present in 80% of the cases at birth, but it undergoes obliteration. But majority obliterate in the first 6 months of the life. And the incidence of inguinal hernia, it has been seen that it's more common in premature infants, especially these children present in the first year of life. And as usual, males have a more incidence of inguinal hernia, and the inguinal hernias appear more on the right side compared to the left side, and bilateral in 10% of the cases which have been seen. So it can be present at birth or it can present later. Majority of the times it will be asymptomatic, detected incidentally by the mother, or when she notices an inguinoscrotal or a labial bulge with the diurnal variation in the size which increases on crying. But very frequently it gets complicated when it becomes an irreducible bulge, and incarceration is common, especially in premature children, which mostly occurs in the first 6 months of life, and it is an emergency and it needs to be operated. So these are a couple of clinical pictures. This is a child with a left-sided inguinal bulge which is incarcerated. This is a girl child with a right-sided inguinal hernia. This is an older child with a large right-sided inguinal hernia. So how do you diagnose? Majority of the times, because it is reducible, when the child is brought to you, will not be able to identify the bulge. And it is said that a reliable history of the parents is enough for you to investigate for a hernia and subject the child to surgery. And sometimes when you palpate the cord structures with your hand, with your forefinger and the thumb, there is slight thickening of the cord structures. That is called as silk glove sign. That silk glove sign, the sac feels like a silk glove compared to the opposite side. So when you are in doubt, you have to ask for a photograph of the bulge when it appears. The parents will usually oblige to that. and subject the child to ultrasound. Its ultrasound is 97% accurate in showing a patent processes vaginalis. What is the treatment of congenital inguinal hernia? It is usually known as herniatomy. It's not hernia. Sometimes in diagnosis, people used to inject some dyes into the peritoneal cavity and take some x-rays. That is known as herniography. So the management is surgery is the choice, and elective surgery is much more appreciated than getting it complicated. High ligation of the patent processes vaginalis, and it is also known as, in simple terms, herniatomy. And when you should do it? You should do it at diagnosis, because it has high probability of getting complicated. It has to be done as early as possible, and especially in premature infants, it is said that they should be operated for inguinal hernia before they leave ICU or when they gain 2 kgs of weight. It's usually a daycare surgery. Either you can use sedation, spinal anesthesia, or regional anesthesia. There have been two schools of thought, lap versus open. I prefer open because you are unnecessarily converting a extra peritoneal procedure in an intraperitoneal procedure. But during learning curve, some people say that hernia gives you an adequate window to hone your skills for other complicated surgeries. That is your take, whether you want to do a lap or a open. So, but open surgery is a simple regional anesthesia, 10-minute procedure, post anesthesia. And lap makes it more complicated in the sense you have to use a general anesthesia, and it has 3 ports. Within that 3 ports, with a single incision in an open hernial surgery, we finish up the procedure. But one advantage of the laparoscopic procedure is that contralateral exploration, because it is said that when you put a scope inside the abdomen, if the opposite ring is also open, the surgery is done on the opposite side also. But to me personally, the people might differ with my opinion. When you are subjecting a child to an ultrasound, it is 97% accurate in picking up the opposite side hernia also. If the patent processes vaginalis is present, the 97% accurately, the ultrasound gives you an idea. So that negates the laparoscopic procedure altogether. And this is a video of herniatomy, how it is done. I got this from my friend Dr. Amar from Ahmedabad. So recently we had done ASI program on the same topic. So I got this video, and I want to acknowledge him, Dr. Amar Shah from Ahmedabad. Here, this is the head end. That is the pubic tubercle which is being marked. The pubic tubercle is an external surface marking for the external inguinal ring. On the lowest inguinal crease, an incision is taken about 1.5 centimeter above the pubic tubercle in the lowest inguinal crease. The incision is made at the inguinal crease. That's usually a 1.5 to 2 centimeter incision. The subcutaneous fat, sometimes you might encounter superficial epigastric artery or superficial external pudendal artery. You ligate them or you buzz them with a bipolar cautery. So once you dissect the superficial fatty layer, you get the deeper scarpous layer, which is a membranous fascia. You hold that within 2 hemostats, open that up. So once that membranous layer, scarpous layer is opened, the transverse fibers of external oblique comes into view. This is a neonatal hernia less than 1 year age. There is no need to open the external ring. They've already got the sac in hand. That is the sac being dissected. The spermatic fascia is being dissected. The bulge which you are seeing is the fluid-filled sac with the pampaniform plexus of veins. Gently dissect without holding the vas deferens with a non-toothed dissecting forceps. Separate the pampaniform plexus of veins and also the internal spermatic fascia associated with that. That is the vas deferens which we are seeing. The white card-like structure which we are seeing is the vas deferens. You are not supposed to hold the vas. Gently dissect it out. Until you dissect the sac circumferentially 360 degrees. Yeah, you can see the gloved finger there. The dissection of the sac is totally complete. Taking care that you are not including vas in your clipping. Ligate it, place an mosquito forceps on either side. Open the sac. See for any contents inside. If there are none, then cut it across. The proximal sac needs to be dissected up to the deep inguinal ring. So how do you know that you have reached deep inguinal ring? So when you start dissecting, you will see an extraperitoneal pad of fat when you reach the internal ring. That's the yellow color structure which is peeping out here is the extraperitoneal pad of fat here. And you transfix and ligate the proximal sac nearer to the internal ring. The distal sac can be laid open. You need not have to, unlike in adult surgery where we tend to dissect out the entire distal sac, the distal sac can be just laid open and left aside because the dissection can cause damage to the vas and the cord structures. Now close the external oblique fascia if you have opened that. Approximate the subcutaneous tissue and the membranous layer of scarpas. Then using the same suture, you put subcuticular stitches. So after 6 months, you will have a scar free. You will even the scar needs to be like found out. You have to look very closely even to identify the scar. So the same procedure. This is again a right angle hernia which we saw. This is a hernia repair in a girl child. So what the difference in a girl child? Sometimes ovary can be present. The procedure is the same. Mark the pubic tubercle, midinguinal point. Take incision 1.5 centimeter above the pubic tubercle for about 2 centimeters. Dissect the facial layers. That is the scarpas fascia which is being opened. And instead of vas difference, there will be round ligament as the content of the sac. Dissect it up to the deep inguinal ring. Open the sac to see if there are any contents. If none, then it can be transfixed and ligated.
Just to fill in the gaps, usually as Diwakar said, in a newborn, this internal and external rings will overlap. So it's called Mitchell-Banks technique. If you cut the external oblique, like say infant 1 year, 2 years, where you are going to cut the external oblique, aponeurus, it's called Ferguson technique or modified Ferguson technique. Newborns, it is overlapped. We just at the tapering, we just ligate the sac. Yes. And Anuradha ma'am was asking about the testicular ascent, like during the surgery or after surgery. During surgery, you just pull back the scrotal skin, ma'am. It will go back into the scrotum. The gubernaculum pulls the testis into the scrotum.
I'll come to that, sir. We have a slide on that.
Yeah.
And as rightly said by Dr. Venkatesh, the technique which is used in children more than 1 year, where we open the external oblique aponeurosis, we call it as Ferguson's technique. And in a neonate or less than 1 year child, because the external and internal rings are overlapping each other, there is no need to open the inguinal canal. So that is called as MB technique or Mitchell-Banks technique. In a girl child, the content can be ovary or the tube can be sliding component in 40%. So you have to take care before you transfix the sac proximally. So the complications of inguinal hernia can be iatrogenic undescended testis, where you fail back, as Dr. Venkatesh was mentioning, when you fail back to pull the testis into the scrotum, sometimes the testis can get fixed at ectopic or at an undescended location. So you have to take care to pull back the testis into the scrotum, or post-surgery, there will be scrotal edema or hematoma. Sometimes, especially when it's a large sac, there is always a chance of you failing to dissect 360 degrees and ligating partially the sac. There will be recurrence of hernia in the post-operative period. And as I said, the VAS needs to be, all this circus is being done only to safeguard the VAS. So you have to be very careful in not handling the VAS. VAS needs to be teased off rather than held. So that way you can prevent injury to VAS. Sometimes if you handle too roughly, there can be testicular ischemia, and as a result there will be testicular atrophy at the end of 6 months. So congenital hydrocele, again it's same as a congenital hernia, the pathology. Only thing is that the internal orifice of the sac will be very small. It also presents as inguinoscrotal swelling, and here you can get about the swelling, and it, unlike hernia, it is irreducible because of the inverted ink bottle effect. Everyone knows about this, I think. And sometimes it will be associated with a hernia. The indication for surgery is that if suppose a neonate is brought to you with a hydrocele, we usually advise them to wait till 2 years of age, because more than 60 to 70% of them get resolved automatically. If an hydrocele persists beyond age of 2 years, then that needs to be operated. A special entity is the hydrocele of the cord, which I showed the figure earlier. So this completes my the treatment for hydrocele is again a herniatomy or the high ligation of patent processes vaginalis. So this completes my hernia topic, sir. I think we'll stop here. It's 8:57 now.
I think, if there are any questions, Gaddi sir is ready to take. See, this newborn hernia, sir has covered neonatal, premature. The incidence of hernia is more in premature. Say, as sir said, it's a persistent process vaginalis. It's there in almost 80% of the children, neonates, premature. So as the child, say 6 months, 1 year of the age, it drops down to 56%, then it comes down to 20%. See, they have done a study in the adults also, postmortem studies. The PPV is patent in 20% of all adults also. So because of this persistent processes vaginalis, the hernia occurs, the hydrocele occurs, all that. So younger the age, earlier to intervene. Hernia is an indication of surgery. We should not wait. Sir has already said before discharge, whether the baby is in ICU or less than 2 kgs, we have to operate before discharge once the baby is settled. There is a question on repair in adolescents. I think it is the same, I suppose, Diwakar sir. Hernia repair in adolescents. It's herniatomy only, yes. I suppose. Yeah.
In my practice, up to 13, 14 years, where the child tends to do heavy work, I go ahead with only herniatomy. If the child is beyond 15 years, and if I feel that something needs to be done for the posterior wall, I usually do a herniorrhaphy, where I bring the conjoint tendon, approximate the conjoint tendon with the inguinal ligament. But very rarely, I have never used mesh in a child less than 18-year-old, sir.
But usually recurrence will be a direct hernia. Usually it is the hernia in children is usually due to persistent processes vaginalis only. Very rare to find direct hernias in children. It's only due to recurrence, probably that transversalis fascia, all that. It needs again herniorrhaphy or like recurrences. We need tissue repairs. Very rare to, as Gaddi sir said, very rare to use mesh, because the children are growing, the mesh doesn't grow. Rather, it shrinks by 40%.
So Sangmesh has asked a question: monopolar or bipolar cautery during dissection? Usually, the bipolar cautery should suffice, because monopolar cautery, there is, as you know, the principle, the current passes through whole of the body, and spread of current is more. And bipolar cautery is limited to a very, the bleeders will be very small actually. It will be more of a oozer, because as you know that pampiniform plexus are valveless vessel. So once you replace them back, usually they stop the bleeding.
Usually in one of the operative books, he just described the incision should be, as Gaddi sir said, distal crease incision. and in between the hypogastric and epigastric vessels. So never touch those vessels. Your incision should be in between those two.
Yes, sir. And Anuradha madam has asked older children where to take incision. The incision is the same place, ma'am. Just
Distal
1.5.
crease. Yeah.
Yes. 1.5 to 2 centimeter above lateral to what you call pubic tubercle, and 2 centimeter incision. If the child is little older, you can extend the incision by a couple of millimeters so that you will be able to reach the internal ring.
Distal crease, usually just lateral to the midline. That's all. It will be the same point as pubic tubercle and above.
Yes, sir. This is very basic topic. I understand that. But there are a lot of nuances involved in this, and it can be a life-changing experience for some people. I'll tell you a story to keep you interested. There was a surgeon friend of mine who has resigned his job. The first, he did some surgeries. One circumcision he went to do. At the time of anesthesia, patient had an arrest. And it completely left the profession. He changed his profession to real estate. Now he's much more happier with some 200 crores in his bank. So circumcision can be a life-changing experience. So don't take it very, very lightly.
But there are some pediatric surgeons who have made 200 crores by circumcision only.
Circumcision.
Like our Tanvir sir, he used to do 100 cases during those summer times.
Yes.
Yeah, I think
in Bangalore.
we'll go to some academic part only. Yes, whatever.
Yes.
Yes, please.
So this canal, hernia of the canal of neck.
Yes, ma'am.
Yeah.
It's you're talking about the female
Yes,
girls.
female.
Yeah.
So I hear in this AWR conferences and everything, and whenever there's a discussion, they
Yeah.
talk about preperitoneal mesh repair and all that. So I just wanted to know how, when to use this, and is it really necessary to do that, or we just do herniotomy in hernia of canal?
Ma'am, as Gaddi Diwakar said, usually we have limited our laparoscopic herniotomies only for girls above 5 years, and we do it bilaterally. Even if it is unilateral or we put a scope, and usually the other thing is also patent. If it is bilateral female child above 5 years, we do a laparoscopic herniotomy. Otherwise, all this pre-peritoneal, all this tip tap and all, there is no, we
Yes.
don't do in pediatric population now.
No,
Venkatesh,
beyond that. Sometimes
Venkatesh,
little older children, sir, should we to do a preperitoneal mesh? Because so much of discussion keeps going on. We are actually confused about actually what is the correct
I
thing
have
here.
already told the children's
sir.
grow, the mesh shrinks.
Yes,
There
sir.
is no role of mesh
Mesh
unless
repair.
the patient has got some connective tissue disorders like
Okay.
Ehlers-Danlos syndrome, Hunters and Hurlers.
Yeah.
There are so many connective tissue disorders, extrophy bladder. There are so many like lax connective tissue, say all that type 3 collagen deficiency, all that, some muscular deficiencies. Very rare indication of a mesh in a pediatric.
Yes.
Right, Diwakar sir?
Yes, sir. We never, as I told earlier, I never used a mesh in children until
Yes,
now.
yes. Only 50, above 15, and if they are muscular, if they are overgrowth, they look like adults. And general surgery refuses to take them because they are below 18. Very rare cases now.
Yeah, can I say something?
Yes,
about
sir.
this?
Shenoy sir, please.
Not hernia. I'm just talking about obviously I'm hydrocele of the canal of the neck. That too, especially, what has been mentioned in the books and, too much, but exceptionally, which is rare. I'm only talking about adults. So females. So canal of the neck, whatever question which was asked, one of the easiest things to perform, inguinal incision only. So I understand the similar strategy if it is found in correct, no?
Yes,
Sir,
Yes.
it is the simple, the mechanism of the surgery principles are very clear, sir, here.
Correct.
We open
Simple.
the external oblique.
Very
We
simple.
find that cannot, we just, in a female, we just literally put 2 mosquitoes and just open up at the anterior wall. We see if there are any contents, say ovaries, tubes, all that, we reduce. The proximal thing is always reduced under vision. Then it is rotated, transfixed, then it is ligated. So reduce the contents. We see, we under vision, we do that canal thing. And sometimes we find, see, there are a very rare incidents of, we call it as disorders of sexual differentiation, DSTs, where we have ovotestis, all that. Very rare conditions, sometimes splenogonadal transfusion. There are so many anomalous conditions. We find surprises in the processus vaginalis, which is a part of canal of neck. So under vision, if we go by principles layer by layer, will not have a problem, sir. Gaddi, sir, you want to add on to this?
Nothing, sir.
Surprises in the as a content of all this hernial sac.
Yeah, as Rajgopal sir mentioned in chat box, the contents need to be visualized. The sac should not be cut across just like that. Open the anterior layer, see the contents, reduce them under vision. Then you complete the cutting of the sac, then transfixation. Twist the sac so that if there are any momentum left at the bottom, it reduces. Then transfix and ligate at the base.
Because Dr. Gaddi, because I forget, since you mentioned, talk about the sliding component, sliding, especially here. So that is something, which is very, very important, because the moment you say that, some twisting and all that, that is one of the major problems of that.
This sliding hernias, the wall is formed by one of the organs, say bladder, bowel, all that.
Especially in children. In children, will not be seeing that kind of a sliding. Especially in a girl child, the fallopian tube, a knuckle of fallopian tube is always attached at the base. You should be carefully dissect that. And once you dissect that, it starts bleeding. You have to take care to control that, reduce it. Then at the base, in those cases, you don't twist. Take a circumferential incision, a circumferential stitch, and ligate it under vision so that the tube safely is reposited back into the peritoneal cavity.
And we can invert. We can invert the sac inside the peritoneum. It's called usually laparoscopy. If you do a little technique, laparoscopic inversion ligation, we can invert here also.
Rightly said. In a girl child, that should not be a problem because there is nothing coming out of it. You can always sacrifice that round ligament for the safety of recurrence, to prevent recurrence.
Have you ever extended the incision?
Sir?
Have you ever extended the incision?
It's rather reverse, sir. As we start doing more, we do it in a centimeter, half centimeter. It's only, we just make a nick and we take mosquitoes and we know where to pick up the sac. As the experience increases, the incision becomes very small.
Sometimes semantically, they say if there is a bilateral inguinal hernia in a girl child, so the sacrificing on round ligament on both the sides can cause some instability of the uterus. What we tend to do is that we resuture the distal part of the round ligament and the sac together, the ligated part of the sac together. I don't know how much, there are no studies which support this, but for your mental satisfaction, we do, this has been practiced by many surgeons, pediatric surgeons, where we approximate the proximal ligated sac and the distal round ligament. So some kind of fibrosis occurs and that will partly replace the lack of round ligament support.
Sarvesha, we need a little bigger incision for a undescended testes, where herniatomy is part of the surgery. All the undescended testes, herniatomy is 100%, sir. We do the hernial sac ligation, then we mobilize the testis and bring it down. That needs a little bit longer incision. Yeah, leave it to the chairman and secretary to decide whether to continue or.
Yeah, before that, since we'll complete that, since Dr. Diwakar Gaddi mentioned somewhere in his that hernia talk, distal sac.
Yeah.
This is, yes, you can leave it. Even in adults, it is not necessary to remove that, number one. It all depends upon how, how long standing that hernial sac distal. Some of them are so much adhesions to have happened between even the spermatic cord and even the vessels. So I've seen so many of this, some of them, trying to remove it and getting into problems of this more damage. It's a surgeon's preference and nothing will happen. The one small problem they have mentioned is like seroma formation.
Yes, sir.
Seroma. If you have any doubts about that, yes, Some of them do get the small thin, that drain out from the below, especially in a giant hernias, larger hernias, where this challenge is there. If possible, most of the time with a gentle dissection, it is possible to remove them. This is just a comments. That's all.
Just to add on to it,
Yes.
and there is a principle that you're not supposed to meddle the distal sac because too much of lymphatics in the distal sacs, once you go into the scrotum, near the scrotum, you're not supposed to touch. It's called secondary hydrocele.
Correct.
So many like lymphocyles, all that. So which, if it is due to seroma or collected thing, it will disappear by 6 months. But if there is a too much of lymphatic destruction during dissection of the distal sac, they may not disappear at all, sir. We should not disturb the distal sac.
I think definitely it is true for pediatrics surgery
Yes,
because
yes, sir. Yes,
this, as you told that these are all the lymphatics and everything should growing that whatever be the time.
yes, sir. Yes, sir. Yes, sir.
So yes, correct. But the principle remains that even distal, even in adults, not just because of the lymphatic in mind. I'm talking about this. This is basically because of the adhesions between the vessels and the cord. That's the only idea. Okay, thank
Yes.
you.
Should we split it and leave it?
Sir?
Illa, sir, you are not supposed to clip, sir. You are supposed to leave
You
it
can-
open because
You can split.
see, for hydrocele, the surgery is the same. Herniotomy only. We don't want that remaining fluid to stay back there. We will leave it open, sir. Distal sac is always leave it open.
You can incise the sac as far as possible.
Yes,
Leave it
yes.
open. Just open
Leave it. You are
Yes.
supposed to leave it open. The fluid gets
That's what I
absorbed.
said. Split it open and leave it.
Yes.
Yes,
Split
yes,
it
sir,
open
yes.
and leave it.
Split it, yes.
Okay.
One
So-
second, sir. Do you have any orchidopexy videos with you now?
Ma'am?
Orchidopexy.
Yeah, I have a
Orchidopexy.
video.
Yeah.
Yes, I have a
Ah.
video.
One play ಮಾಡಿ.
You can just play ಮಾಡ್ಬಿಡ್ರಿ.
Yeah. Yes, I'll show that. Yeah, similarly, the incision is marked just above the pubic tubercle in the lowest inguinal crease.
The incision being given.
Naaz ma'am, there are two entities in undescended testes. One is palpable and non-palpable. Palpable is usually clinically under relaxing Fox position in the OPD. Relaxingly, we palpate. So palpable, they are done in the minor OT itself. So doesn't need any diagnostic scopy, all that. Non-palpable is imaging may not help. The MRA, they call it as so many things. So there, we put a scopy and see non-palpable UDTs. So laparoscopically, we can do 2 stages or 1 stage. And this is an open orchidopexy for palpable undescended testes.
Separating that from the chromastic.
And the herniotomy is a mandatory for all the tests, undescended tests.
Usually 80% of the undescended testes are associated with inguinal hernia.
Yes.
So the herniotomy is the first step before we bring down, and herniotomy also helps you lengthening of the cord so that the testis reaches the bottom of the scrotum. So it's always slippery. So hold it. That is the entire sac containing testis as a component. There is a transparent appearance in between that U-shaped thing. Yes. So the one thing when this is the distal part which is being cauterized. So before you cauterize that, you should make sure that there is an entity known as long loop vas. The long loop vas, what it does is that from the testis it goes down into the scrotum, then comes back. So before you cutting that distal part, you should be very sure that there is no long loop vas. Now the sac is being dissected out of the spermatic cord structures. Just gently tease it out. So that is the vas being separated from the sac. So the sac has been dissected 360 degrees. So before clamping, you should make sure, doubly sure that vas is safe and away from the harm's way. So after confirming that vas is safe, the cut. So once you cut the hernia, that automatically gives a length for your testis to come down into the bottom of the scrotum. Similar to the herniatomy, dissect the sac proximally up to the internal ring, where you can see in the distal part, the pad of fat near the internal ring. There you ligate, transfix and ligate the sac. If you feel that the length of the cord is less, still less, you can do some retroperitoneal dissection. If you go deep to the internal ring, there are certain attachments of the peritoneal structures to the cord structure that is called as ligament of Berry. So you can always dissect them out. That will give a couple of millimeter extra length for your testis to come down into the bottom of the scrotum. Or if the testis fails to reach the bottom of the scrotum, you can always fix it at a higher position. And if at all you want to do a redo surgery, it can be done after 6 to 8 months, where the testis can be mobilized still further and can be brought down to the bottom of the scrotum. So once the sac is ligated, you push your finger through the external ring into the scrotum to create a subdartos pouch where the testis is placed safely. Insert your finger.
It's actually a misnomer. It's called extradartos. It's between the skin and the dartos. You have to make a space. Yes.
The incision is made in the skin. Or you can say within the layers of the scrotum, so that the testis is not retracted.
So we are making a third ring in the dartos. There is deep ring, there is superficial ring. We are making one more ring in the skin and the dartos.
So when you are pulling the testis down, you should see that the spermatic cord is not torted. The direction should be such that vas at the internal ring, vas goes medially and the vessels go laterally. That's usually the normal anatomical position of the vas and the vessels. You should not hold the testis. You should hold the gubernaculum process and gently pull the testis into the incision which you have made in the scrotum. Once you bring it out, you can close the opening in the dartos with an absorbable suture on either side. If you have mobilized the testis properly and if it's come down into the scrotum very easily, there is a less likely chance of the testis getting retracted into the inguinal canal again. So if it has been mobilized properly, there is no need for anyone to take a stay suture through the testis or the peritesticular tissue. They are confirming whether the alignment of the vas and the vessels are normal. Once it is confirmed, the testis is gently pushed into the subdartos pouch with a non-traumatic or atraumatic dissecting forceps. That's called, we call it as vascular forceps. When it is safely deposited in the scrotal pouch, the skin is closed with a couple of absorbable sutures. The testis has been mobilized properly, as it can be seen that it's not getting retracted or there is no puckering of the skin even after the closure of the opening in the dartos. That's the third ring which Dr. Venkatesh was mentioning. So after closure of the scrotal incision, then come back to the inguinal incision, close the external oblique aponeurosis if you have opened that, including the external ring. Here, unlike herniotomy, the external ring is also laid open for your finger to get insert into the scrotal, what you call, along the proposed route of the spermatic cord into the scrotum. Close the subcutaneous tissue, and again a subcuticular closure of the skin is made using the same absorbable suture. This is the end result of the surgery, where this is single stage open archidopexy. And this video I got it from Dr. Krishna Kumar, who is professor at JIPMER.
Very good videos, very good demo, Gaddi sir.
Thank you, sir.
One question I have, because this is one of the commonly asked questions.
Yes, sir. Yes, sir. Please go ahead.
You have brought this testis down, whether it's cryptorchidism or whatever what is the chance of malignant potentials in the testis which has been brought down? Means, does it remain the same or does it improve? That's the only question.
Depends again on the position of the testis pre-op, sir. If it is intra-abdominal, there is more chances. If it is in the inguinal region, it is, I said, the palpable, non-palpable. Non-palpable has got more chances. And it's very late, sir. Maybe third decade, fourth decade.
No, that's
we
what
don't
I'm
see.
asking.
Yes, sir.
My question is, we
Yes,
know about the incidences in adults. What I'm trying to tell is, because this is a question, because testis which has been brought down into the, let us say, right-sided scrotum, because there's an incision there. See, now there's a patient who develops a testicular tumor. So this is one of the questions which is asked, in the sense, has it broken the barriers? You understand my question?
Yes, sir, I understood that.
That's what is the question.
The incidence, as
means
I said,
an incidence. Yes, please.
Yes, the ideal time when the testis need to be brought down, earlier they used to say 10 years, 12 years. Now the concept is it has to be done within 1 year of age.
1 year.
Because as the age progresses, there's every year approximately 10% decrease in the spermatogonia. At 2 years, it may be 80%, 3 years, it may be 70%. And again, the incidence of malignancy depends on the position of the testis. For a palpable testis which is lying outside the inguinal canal, the incidence is as similar to the general public.
Okay.
If the testis is intra-abdominal, and if you tend to bring it down very early, like in 1 year, the incidence is same like general public. But if you fail to bring it down, say up to puberty or up to what you call late or early adulthood, then the incidence is said to be 0.16%. That too is very low compared to the general public. And as you said, because we would have breached the skin barrier, definitely it theoretically upgrades, if at all a tumor occurs, theoretically it upgrades the stage of the tumor. Correct, sir. Hope I have answered your question.
Definitely. Because these are... I think
sir,
if there's any questions and comments by Dr. Venkatesh, check in the chat box. And
yes, sir, I'm checking.
And then probably by another 3-4 minutes, we'll wind up 5 minutes. Okay,
yes,
please,
sir.
go ahead.
So one more comment, sir. This is for a palpable testis. If there is a non-palpable testis, with the advent of what you call laparoscopy, it has become very easy. Put in a scope. So see whether the testis, which is intra-abdominal, reaches the opposite internal ring. So if it reaches the opposite internal ring, it can be brought down in one stage into the scrotum. Using laparoscopic assisted, you can do an open technique also. But if it fails to reach the opposite side inguinal canal, it definitely requires a 2-stage procedure. It is called as the Fowler-Stephens 2-stage procedure. In the first stage, we clip the gonadal vessels intra-abdominally. It can be done either if you don't have a laparoscope, it can be done with a incision where you explore either retroperitoneally or through abdominal peritoneal cavity. You can approach that. And in the second stage, first stage, 6 months, the second stage is done, where theoretically the testis would have got blood supply from the artery to vas. So post your the clamping of gonadal vessels, you bring it down into the scrotum in the second stage. So this is for non-palpable testis. So
Done.
this theoretically completes both the procedure for palpable and non-palpable testis.
Testicular vessels are the limiting factors for the descent, sir. So in Follow Stephen, we just clip and do it after 6 months. There is one more method called Shehata from Egypt technique, where we don't divide the testicular vessels. As the Gaddi sir said, we just pull the testes to the opposite side and fix it there so that it stretches and it grows. So after 6 months or a year, we again try to bring it out.
Was that something like that when we were that there used to be omelette in a procedure, something like that? Fixing
Yes,
to
sir.
the opposite side?
Yes, sir. Yes, sir. Yes, sir. It's called
Because-
Shehata, Egypt. Yeah.
Yeah.
So it stretches, it grows. So if it goes to the opposite side easily, as Gaddi sir said, we can bring it in a single stage.
Because that was our one of the
Yeah,
questions that time.
Yes,
Okay.
yes. Yeah. There are lengthening procedures. There are so many procedures. So it's called Prentice. It is called Lariaga technique, where the vessels are the limiting factors.
Correct.
The inferior epigastric, we can bring it below the vessels, or we can divide the inferior epigastric. We can straighten the course of this testicular vessels with the testis. It's called direct. We do it in laparoscopy. Na? We bring it through the direct, like a direct route, rather than going through the normal route of deep ring, inguinal canal, superficial ring, then to the scrotum. And Diwakar sir has appropriately has put all this disorders of sexual differentiation. Usually we used to call hermaphrodite, pseudo-hermaphrodite, all that. So female phenotype, suddenly you have a testis in the labia. So it's called androgen insensitivity.
That's a very vast topic.
Very rare, very rare, very rare. We'll not complicate the talk.
Yes.
Yes. Today we will, I think, stop at this level.
Simple pediatric surgery.
Yes, thank you.
Yes.
Basics.
Basic, yes.
The only thing we have to keep in mind is if there is bilateral undescended testis non-palpable,
yes,
then you have to work up for intersex disorders.
Yes, sir. CH, all that. Adrenal hypo, all that. Especially when they have bilateral undescended testes, hypoplastic scrotum, the hypospadias, all that. Proximal penile hypospadias, all that. I think Sarvesha can conclude. If there are no questions.
Chairman, sir.
Yes, sir. Because I think it's important that they have given time for us. But that's very important. They are part of us only. Both of are very, very.
Anytime, sir. You need not have to thank us also.
Sir, please, Dr. Sarvesha, please.
Yeah. It was a nice talk, Dr. Gaddi Diwakar, moderated by Dr. Venkatesh. I thank today's speaker, Dr. Gaddi Diwakar, Honorary Secretary of ASI, and our own GC member and our member. Thank you very much, Dr. Gaddi Diwakar, sir.
Thank you, sir.
I thank today's moderator, Dr. Venkatesh, Chief Editor of KJS, and very nicely moderated today's session, sir. Thank you. Thank you very much. I thank our chairman, Dr. K. Rajgopal Shenoy, for conducting the program since March 25. And we are going to continue that one further also. Thank you, sir. I thank Dr. Naaz, Chairman-elect, past President Dr. Narayan Hefsur, past Secretary Dr. N. Chandrasekhar, and I thank Dr. G. Siddesh. He is the Social Service Council Director.
He has joined. Yes.
And I thank all our EC members, GC members, and all members who have participated in today's program. Thank you all. Good night.
Thank you, sir. Siddesh sir, namaste. Chandru, namaste.